Neurology Quiz number 113. Describe the various modalities for managing drug-resistant epilepsy. As discussed in the previous quiz, the following are the different kinds of epilepsy surgery. Resective surgery was discussed in the last quiz. Minimally invasive surgery, laser interstitial thermal therapy or LIT. A laser is used to precisely target and destroy a seizure focus with controlled heat, guided by real-time MRI imaging to locate the target area and monitor the temperature of the tissue being treated. This allows for a targeted treatment with minimal damage to surrounding brain tissue, resulting in a faster recovery compared to traditional surgery. It is minimally invasive, unlike open craniotomy, and only requires a small incision to insert a laser fiber into the brain. It has a faster recovery time compared to open surgery with potentially fewer complications. This slide shows laser interstitial thermal therapy. Figure number 1 shows the laser probe. Figure number 2 shows probe attached to patient's skull in an MRI machine. All components are non-metallic. 3 shows robotically controlled ablation with simultaneous cooling of the surrounding brain. Stereotaxic radiosurgery. This technique utilizes highly focused beams of radiation, such as a gamma knife, to target the seizure focus. It can be an option if patients refuse open surgery. Post-procedure side effects include cerebral edema with severe headache, papilledema, and visual deficits. Palliative surgery. Hemispherectomy or functional hemispherotomy is performed in selected patients with severe epilepsy arising from one hemisphere, such as Sturge-Weber syndrome, Rasmussen's encephalitis, and large perinatal strokes. Although decrease in seizure frequency with hemispherectomy may be noted in 80% of patients, the risk of postoperative complications such as hemorrhage, late hydrocephalus, and hemosiderosis is high. Hemispherotomy aims at minimizing extent of brain removal while maximizing white matter disconnection to reduce incidence of complications. This figure shows hemispherectomy on the left, which involves removing the diseased hemisphere, including frontal, parietal, temporal, and occipital lobes. Deeper structures such as thalamus and basal ganglia are left in place. There is a higher incidence of complications. It is usually done if hemispherotomy fails. On the right side, the figure shows a hemispherotomy where less brain is removed, but the diseased hemisphere is completely disconnected from the normal parts of the hemisphere. The procedure can be equally successful at preventing seizures. Advantages include shorter surgery, less hemorrhage, and lower incidence of hydrocephalus. Disconnective surgery. The aim of disconnection is to isolate epileptogenic zones to achieve seizure reduction. Corpus callosotomy is primarily performed in children with disabling drop attacks to prevent interhemispheric seizure spread. Postoperative complications include disconnection symptoms such as language decline and unilateral deterioration of motor functions. Multiple subpile transections. This technique involves numerous perpendicular cuts, usually 5 mm apart, through the gyrus to segregate intracortical horizontal fibers. While sparing subcortical white matter, such interval cuts may prevent the spread of epileptic discharges. This figure shows corpus callosotomy. A bifrontal craniotomy is performed, and via an interhemispheric approach, an anterior 2/3 of full callosotomy is performed. This figure shows MST, the principles of performing a subpial transection. Instrument is inserted in the subpial plane and passed along a gyrus, disrupting horizontal interneural connections, but preserving the vertical functioning unit. Results of epilepsy surgery. A review of more than 16,000 patients in 2015 found that 70% of patients in the surgical group and 7% of those in the medical therapy group were free of disabling seizures at 1 year. The 5-year seizure-free rate was 66% for patients who had undergone temporal lobe resection, but only 28% in patients who had undergone frontal lobe resections. Some studies have reported that anterior temporal lobectomy had a better long-term outcome than selective surgery, but others studies suggest that the outcome may be similar. When seizures recur, they are typically less frequent or less severe than before surgery. Although some patients may have cognitive improvement secondary to seizure control, other patients may develop cognitive decline after surgery. Epilepsy surgery is also associated with lower incidence and lower overall mortality from SUDEP, with the lowest risk among patients who are seizure-free. This figure shows epilepsy surgery grading scale to determine chances of success after epilepsy surgery. A score of 8 to 10, grade 1, indicates high chance of seizure freedom, more than 70% following surgery. A score of 4 to 7, or grade 2, indicates moderate chance of seizure freedom, 40 to 60%, and a score of less than 4, or grade 3, indicates a low chance of seizure freedom, less than 40%. Neuromodulation. Neuromodulation is offered to patients with drug-resistant focal epilepsy who are not candidates for surgery due to the following. They have poorly localized multifocal epilepsy. They are poor surgical candidates as the epileptogenic zone overlies eloquent cortex. They are unwilling to undergo surgery. VNS is also approved for drug-resistant generalized epilepsy in children and Lennox-Gastaut syndrome. Vagus nerve stimulation, or VNS. VNS was first approved for drug-resistant focal epilepsy in the United States in 1997. The VNS pulse generator is implanted in the skin on the left side of the chest, and the lead is attached to the left vagus nerve. The mechanism of action is unclear, and hypotheses include desynchronization of hypersynchronized cortical activity. VNS therapy is considered in patients who are not candidates for or are unwilling to have surgery or have poorly localized multifocal epilepsy. It is also considered for drug-resistant generalized epilepsy because of the limited surgical options available. This figure shows a VNS with the lead attached to the left vagus nerve and the pulse generator inserted under the skin. Trials have demonstrated more than 50% reduction in seizures in 25 to 60% of patients. Older models are open-loop fashion with stimulation occurring at regular intervals set as on and off periods, and provision for on-demand stimulation with a magnet swiped by the patient or caregiver at seizure onset. Newer models provide closed-loop or automatic stimulation upon detection of predetermined tachycardia threshold. This is especially useful in patients who experience increase in heart rate at seizure onset. Adverse effects occur in up to 10% of patients and include infections, local hematomas, and vocal cord paralysis. Voice change, cough, and pain may occur during stimulation. Responsive neurostimulation, or RNS. This was FDA approved for adults in 2018. RNS can detect seizure activity and respond by stimulating the cortex to abort a seizure using a closed-loop paradigm. Electrical currents are applied directly to the brain with depth electrodes implanted into deep surgically inaccessible cortex or subdural strips on the cortical surface. Up to 2 separate electrodes are inserted into the stimulator and remain active at any time while the stimulator itself is implanted under the scalp. It can also record electrocorticographic data, allowing for monitoring response to therapy. It is not indicated for generalized or multifocal epilepsy with more than 2 foci. Adverse effects are usually periprocedural and include hemorrhage in 3% and infection in 12%. This figure illustrates RNS. A neurostimulator is placed under the scalp. It is connected to 2 electrodes placed either on the surface of the brain, in the brain, or a combination of both. The device continuously monitors brain activity and is programmed to detect seizures. When a seizure or seizure-like activity is detected, the device delivers a small amount of electrical current to the brain to prevent or stop the seizure. Deep brain stimulation, or DBS. DBS was approved in the United States in 2018 for treatment of drug-resistant focal epilepsy with or without secondary generalization who have failed at least 3 anti-seizure medications with an average of at least 6 seizures per month in the 3 previous months and no more than 30 days between seizures. Depth electrodes are typically implanted in the bilateral anterior nucleus of the thalamus, and studies have shown significant benefit both in the short term and long term. The mechanism may be related to decrease in synchronization of epileptic brain networks. Complications include periprocedural complications, such as infection in 6% of the cases. Other side effects are directly related to stimulation and include paresthesias, worsening depression and memory in 15 to 20%. Long-term studies have shown that issues with memory and mood can improve over time. Data from studies suggests that DBS and RNS appear to be associated with higher seizure freedom rates than VNS, but at the cost of greater invasiveness. VNS does not require a craniotomy, is low maintenance from the patient's point of view, and can also treat depression, which is often associated with epilepsy. RNS is the only method that delivers neuromodulation at the site of seizure onset and also provides long-term seizure recordings from the ictal zone. DBS might be preferred in patients with epilepsy arising from one or both temporal regions, a subgroup in which it may be especially effective. This figure shows a summary of DRE treatment options and reported seizure freedom rates.